I
So
have the
let's
privilege and
question.
pleasure to introduce my best friend and colleague, Marcel Ivanov, whose introduction will last for hours together, but I will shorten it. He is currently the chair of EANS Examination Board. He is also chair of Aospine UK and Ireland. He is a prolific teacher and writer. He teaches on various spinal courses, not only nationally but internationally. I am told by his colleagues that he is the most widely traveled neurosurgeon in the country, and most importantly, he is somebody who makes working with him very easy, and his center of activity is patient focused in improving the spine care. With that introduction, I would hand the floor to Marcel. Thank you.
Pragnesh, thank you so much. You're too kind. With one caveat, I'm already a past chair of the Aospine UK, but I really enjoy the experience now with Alp, who is the chair of the Europe. We're part of the European board. And thank you very much, first of all, for this invitation and for this opportunity to collaborate together between WFNS. Sorry, I'm sharing something different. Stop share. Between WFNS and Aospine. So this talk is about navigation, and let me find the. Okay, can you see it now?
Okay. Yeah, we see
so
it.
This is about navigation, and first of all, I would like to say that this is not against technology. I am really a strong advocate of technology-assisted spine surgery. If I have something useful and meaningful, I'll be the first one to push for this and get in. And if we believe that this is going to be for benefit of our patients, for the surgeon's benefit, for the hospital benefit. Now, my argument today is that navigation, it delivers everything that robotic is promising. Stacy already mentioned, Stacy did a really fantastic talk, lots of benefits, but I think we'll need to deep dive slightly into this. And these are my disclosures, which I have to mention, really not related to this talk. And what I would like to say is that when we talk about robots, we have some expectations. So what we really want to see is that the robot will do the job, and while the robot is working, we will do something else. Yeah, so we can rest, we can do what is doing the job. So in real life, it's been widely implemented. So the robots, they can clean my room, they can take care of the weeds in the garden, they can prepare a bread, they can cook a pizza, and I can do something else. I can read a book, I can play tennis, I can play chess with my son, and this is what is. Now, in medicine, in surgery, this is recent, yeah? So something like this started happening. This is one of the cases which has been done this year, Johns Hopkins. This is the surgery which was done from skin to skin by the robot without any human intervention. And this is great. This is what I would really like to see in spine. We are still very, very far away from this. So Stacy mentioned the first spinal robotic system. It was approved by FDA more than 20 years ago, 2004. And despite these 2 decades of evolution in spine surgery, we are not there yet. The robots, they do not drill, they do not insert the screws, they do not decompress, they don't realign the spine, they don't remove the tumor. The only thing which is done by the robot, it is holding this trajectory, holding the tube. So they accurately align the surgical instruments with the trajectory which has been calculated either by a robot with human assistance, and it just brings it to this trajectory. We spine surgeons, we are in charge of everything else. Yeah, so we cannot relax, we cannot go in our office and do something else. We cannot play chess, tennis, read a book. We have to be there and still do our job from the scratch. So at this stage, we really don't have a robot. Robot is a machine which is capable of carrying out this complex series of actions automatically. So the real definition of this is not a robot, it is a cobot. Yeah, so it is just part of the activities. So in this presentation, what I would like to show is that the assistance we already have from spinal navigation is already doing the job just well. So considering that most of us, if not all, most of them already have navigation routinely, we should really critically assess what additional benefits the robotic technology brings and what is important at what cost. Yeah, so in the next few minutes, I would like to try to cover two main things. First one is the benefit of navigation. Second one is compare it to these claimed benefits of the robotic assisted surgery. So I'll try to be provocative and I'll demonstrate that robotic surgery, despite much higher costs at this stage, in my opinion, it still doesn't have a palpable or doesn't provide any material difference compared to all this data. I think we should frame the debate properly. So what does a spinal robot actually do today? As I mentioned, it just calls this trajectory. That's it. It doesn't do anything more than this. The intelligence, the 3D imaging, the registration, the real-time guidance, all that comes with the navigation systems, which is integrated now into the robot. So the real question, does this adding mechanical arm to hold this trajectory, does it really justify the cost, which we'll cover in a separate slide? So let's look at the main claim benefit of the robot. So the main claim benefits of the robotic spine surgery, they include improved accuracy. Stacy mentioned about the lower radiation exposure. Stacy mentioned about timing of surgery and less tissue disruption. And I agree with this. This is all benefits which we see, but I think what is important is to make sure that we are comparing apples to apples and not apples to oranges. So all these benefits in most of the papers which you will look at, this is the benefits which compare robotic to standard non-navigated spinal surgery, freehand or X-ray guided. So first of all, let's look at this argument of accuracy. So this is one of the primary arguments of robotics. Yeah. So as I mentioned, what is really important to understand is that most of the papers, they compare the accuracy of the robot to the freehand accuracy or to X-ray guided accuracy. This is one of the, I think this is the largest meta-analysis which looked at all the existing meta-analysis. They looked at 77,000 pedicle screws. They looked at the accuracy of the placement and they looked at the accuracy of freehand, X-ray guided, navigation guided, robot guided. One of the conclusions is that there is no difference between robotic and navigation spinal surgery. So no statistical difference. This is very important to understand. Better than X-ray guided, if you look at all the meta-analysis, but if you compare robots to the navigation, it is very much the same. Now, there are few more meta-analyses, screws, yeah, 77,000, 31,000, really no statistically significant difference between these two ways of inserting the screw. Some papers, some meta-analysis, they say that this is just equivalent and they combine navigation and robotics under the same roof. Yeah, so that's important to understand. And if you look at some selective papers, this is another meta-analysis, 78 studies, looked at more than 7,000 patients, more than 50,000 pedicle screws. Accuracy, interestingly, navigation was the dominating, most accurate. Interestingly, freehand was quite accurate in this meta-analysis. And interestingly, robot was less accurate than freehand. Not clear why, but that's one of the papers. This is the results which one of the papers published in World Neurosurgery 6-7 years ago. I presume technology evolved a lot. I would assume the robot is much more accurate, and I would agree what Stacy mentioned, 95, 97%, 98%, that's what we would expect if everything runs smoothly, but this is very much the same between robots and navigation. So why robots fails, why the accuracy is not good, we can see in papers, various publications that look, despite robots, the screws are misplaced. And there are a few reasons. One of the main reasons is if we look at the cervical spine. So what we would like to see, we would like to place the screw, the drill on the vertebra and have the screw inserted directly into the pedicle, which is usually narrow. This is between vertebral artery, spinal cord. What in real life is happening is that when you apply the screw on the cervical spine, which is a flexible structure, the spine is rotated, and frequently this will not be recognized by the robot. The reference frame is attached to one of the spinous processes, and it may not recognize completely this kind of rotation of the spine unless you have this reference frame attached to the same vertebra. So this is the only case when the robot will recognize rotation of the spine, which clamp to each vertebra before inserting the screw. So usually we'll attach it to one segment and then navigate on the rest. So this can be really helpful in a rigid spine. And this is my experience with the robot. I really liked it. This is a rigid cervical spine, stiff, kind of very degenerative. There is no flexibility. The trajectory is perfect. You can see this. What I've done, I've cannulated the pedicle with the robot guidance, and then I've done a 3D X-ray at the end of this procedure just to check how accurate was this. And it is really impressive. I must say, I really like it. But I can do exactly the same with the same accuracy, with the same precision, just using navigation. So what is important to understand is that in navigation, you can still do the same as we do with robotics, but we have some additional benefits. Yeah. So in addition to kind of strict rigid trajectory, we have a human tactile feedback. So when we are drilling, when we're inserting something, we can feel the difference between the bone and soft tissue. We can see if the spine is rotated. We can adjust, we can accommodate, especially if this is an open surgery. So yes, this is good, but this is equally good. Now, complications. Yes, we don't want to see complications. And Stacy mentioned that the robot can reduce the risk of complications. But this is, again, if you compare to freehand or X-ray guided surgery, if you look at the comparison between navigation and robotic surgery, there is no difference. And this is one of the papers published just a few years ago, Neurosurgical Focus, 100 robotic cases. This is first 100 cases, so there is a learning curve which we need to accept. But from this 100, you have 20 screws-related complications. This included near misses. There was neurological injury. Several cases, several surgeries have been abandoned because of this. And we do see this screw as in the image. First of all, I mentioned this rotation of the spine, especially when this is a flexible cervical spine, different to thoracic spine. In thoracic spine, you don't really need any navigation in experienced hands. But there is a risk of registration errors, and there is an important risk of skiving. And yes, technology is evolving. High-speed drill can help to reduce this skiving phenomenon, but it is there. And as a result of this, we don't have this 100% accuracy, which we would like to have. This is below. This is the really good paper which was published just recently. It's an analysis of all the FDA reported complications related to the use of robots. So in 10 years, more than 1,346 adverse events have been reported. It caused, each of these on average caused 58 minutes delay per event. And 66 of these complications were because of the accuracy problem. Yeah, so 34% of these complications required abandoning of the surgery with the robot. So interesting paper. Yeah, really would recommend everybody to look at this. Now, navigation guided surgery, it does help to reduce the complication profile. I mentioned about, this is another paper which showed that with if you compare robot to navigation, For some reason, in cases where robot was used, there was much significant blood loss. I still don't understand why, but that's the result of the paper. And there was acute kidney injury. There was some higher chance of having blood transfusion. So this is this is a significant number, which we need to acknowledge. Now, what is important is that the robot is still a very good tool for using the screws, for screws, but navigation can use it the same for the screw placement, but it can do so much more. So it's not just pedicle screw and cage placement or sacroiliac joint fusion. It can help to do things which robot cannot even dream of.
Sorry, Marcel, you are in between. Your voice is breaking. We are unable to hear you in between. I don't know, it is a problem with others as well.
Yeah, same for me.
Yeah, I
We
think
can't hear you and you are frozen.
I think we've lost Marcel.
Can you hear me now? I will switch
Yes.
the video. Can you hear me better now?
Yeah, we can hear you now. Thank you.
Okay, I apologize. The internet connection in hospital is not great sometimes. That's something which is beyond my control. So what I was saying is that navigation can provide much more than just the screw placement. Yeah, so it can be good for tumor resection. We can define the edges of the tumor. We can use it in intradural pathology. Stacy mentioned about augmented reality. So additional benefit of navigation is particularly good in tumor surgery, non-instrumented cases, basically anywhere where we would like to see, to have the kind of cases when we need to realize the unexposed anatomy. So this is one of such cases, patient with a big dumbbell tumor, which is both intraspinal and extraspinal. With the navigation, with this augmented reality, we can define the edges of the tumor. With the navigation, we know exactly how much bone to remove. In addition to this, we know that if we want to maintain the integrity of the tumor without violating capsule, that can be a really helpful tool. We can insert the screws with a really great accuracy, transpedicular screw in the C-spine, and then they do the complex part of the surgery, take the tumor out, remove the intradural component when necessary. I think I'll skip through this because that's not the main topic of this presentation. And at the end have a good result with stable spine. Augmented reality is something which we routinely use for a good few years. It is fantastic to see, which I don't think is robot still has offered any of these opportunities yet. So basically, in addition to normal spine, what we can see the projection of the tumor, we can see the projection of the vessels of the spinal cord before taking the bone out. So this is some of these intraoperative images just to show us the benefit. You know exactly how much bone to remove, you know, even in thoracic disc herniation. So this is additional benefit. It can be really helpful for intradural pathology, so you don't have to divert your attention to use ultrasound. You know exactly that the lesion is there and open it up. Now, most of the promoters of the robotics, they will try to convince you that time per screw is shorter with the robot comparing to navigation. And I think it depends on the study. And the truth is that once the patient is registered, then the screw placement itself is quick. It can be really beneficial if you have 20 screws to insert, but what people tend to forget that it takes a lot of time to prepare, to set up the machine, to do the registration, which is significantly more than what is done in non-robotic surgery. So a couple of papers comparing this, and a robot, unfortunately, is not winning in these cases. So this is another paper on surgical time for a standard Peev procedure, freehand versus robot. With the robot, it was, I think, half an hour longer comparing to freehand. Now, radiation exposure, I think this will be comparable. It will be the same as with the navigation. Lots of papers on this. It is clearly zero radiation exposure to the theater staff, to the nurses, to the surgeon. We can protect ourselves, but with navigation, we basically step out of the operating room. we do this 3D spin, which will generate image for us. It is zero exposure, and I presume it will be exactly the same for a robotic surgery. So there will be no difference between robotic versus navigated surgery for this kind of cases, and will generate equally good image at the end. And we should remember, for open cases, we have situations when we really don't need to have any registration at all, because we can do registration based on the surface matching only. So if you have an open surgery, patient already had a fracture, you need to stabilize the spine, you do no need for extra time to do spinning, robot registration, and so on. It is all already there with navigation, and that's something which needs to be acknowledged. We discussed about complications. I will not say too much, but this is, again, one of the papers looking at conventional versus robotic surgery. You can see a big difference between these. Now, the elephant in the room is the cost. So let's talk about money, because ultimately, the healthcare system in all of our hospitals, they must justify our investment. Yeah, so the cost of the robotic spine system is on average between 600 and 1.5 million. This is from the literature, because there is some variation between hospitals. There are some deals imposed by the sellers of the robots, but this is the real cost. Yeah, 600 up to 1 million per equipment. And this cost effectiveness analysis from 2026, which I mentioned already, it says that the cost per patient when a robot is used is increased by $4,000, more than $4,000, which again, it's a big number per case in addition to the cost of navigation. There is a paper which I'll mention later. If you do it with navigation, the navigation is already there. It is a cost-saving procedure. The robotic one is usually it's a significant cost loss. On average, it is $1,500 per case for the pleasure of using the robot. And we should not, forget about the operational cost that comes on extra money. Now, perhaps most demanding is this paper of Schneider. Yeah, this was published very recently, 2026. They looked at 189 economic scenarios, incorporating all this real world adverse event from FDA database. And what it says that probably 10 years. But to justify the cost of this equipment, of a robotic equipment, you need 34 years. Yeah, so 34 years, the time when eventually you will break even the invested money and the cost. So that's something which is important to understand. Again, several cost analysis on quality. I think for the sake of time, we'll skip this. But without any doubt, there is a significant cost implication, which is reflected in this table. So you have a capital cost for navigation. Most of us already have it. If we don't have it, the cost of navigation equipment is, I think, at least 3-4 times smaller than the cheapest robot. The capital cost, we already have it. And it is frequently shared between the specialties. So knee surgeon, neurosurgeons, they do have it, and the capital cost is shared. For robotics, you need a dedicated cost of 80,000, 150,000 per year. And then you have a cost per patient. So the navigation, according to the paper which was published, I mentioned before, it does save this amount of money per person, per patient. The robot is more expensive. Yeah, so that's again important to recognize. This is the reference for those who are interested to read this. So having all this evidence, yeah, we know that accuracy is not different, radiation is not different, the costs are significantly higher. Why the robots are still used? And this is a very important question we should ask. And let's be honest about the drivers. Yeah, so the robotic system, they are powerful marketing tools. Just the fact that we have a robot in a hospital is a compelling message for the patients. It is important for the other referring physicians. Oh, this hospital could buy a robot. It means that this is a good hospital. Now, industry relationship and these financial incentives, they do have a play a role. Many hosts, can you hear me?
Yeah, we can hear you.
Internet is bad. Patient is attracted by the hospital which has a robot. It is attractive for the surgeons to go to the hospital which has this kind of toys. And there is a perception of innovation which is different to the evidence of superiority. That's something which really has to be acknowledged. Yeah, so a lot of industry pressure. Still, why robots? If you have a robot, a hospital buying robot, this usually comes into the news, it comes into the media. It just says that this is a hospital which has a different status. But is it a really incentive to buy it? Now, it looks good on the news channels and newspapers when your hospital is described first in the UK, first in Germany, first in whatever country you are coming from. This is the press release from one of the UK hospitals. They say that this robotic navigation platform will further ensure that the trust provides accurate and excellent care to the patients and help to reduce the waiting list, which also improves overall patient satisfaction. I'm really curious to see how this can help to improve the waiting list. You will be amazed how many first surgeons to perform robotic surgery in spine you will discover on the social media. Every week there is probably some message, the first robotic surgery in whichever region you're coming from. So probably close to the number of robots which have been sold in all these places. So vanity is definitely one of the favorite sins. Yeah, so company industry, they're really aware about this, so they usually exploit it very aggressively. So be aware about this danger. This is one of our friends from AO. This is obviously it's not a real it's a real photo, but he specifically designed this photo for this presentation.
Thank you very much, Marcel. That was a very, very thorough and educational presentation. I will now ask my friend and colleague from Turkey, Alpaslan, to take on the questions and moderate the rest of the session. If I may.
Thank you, Pragnesh. And I also would like to thank Stacy and also, of course, Marcel for their great presentations. And we clearly understand that we need this both technology. I'm personally is a deformity surgeon, so I'm using the free hands for a long time, and of course, I try to use navigation for especially for patients like neurofibromatosis and so on. But it's not that easy actually to how do you say start because obviously as both lecturers mentioned that we need a really steep learning curve and long learning curve during that time, and also maybe a very well established setting in the hospital, and also good technicians for covering this important actually technological advancement. I just want to give a rebuttal actually opportunity to Stacy, because the Marcel already mentioned that the robotics you need to use only robotics in the during the pedicle screw insertion. So the only difference is the tube. So what do you think, Stacy? Is this is the case, or you have a different kind of point of view regarding this important point?
So I take everything that Marcel said. I use both navigation freehand or freehand navigation as well as robotic navigation. So I am a full fan of all forms of navigation. So I take everything he says. The advantage, yes, the robot at the moment is still predominantly for pedicle screws, and we know that. But what it does do is it does bring things like single position surgery to the forefront. So rather than having to change position, so if you're doing a lateral cage, so rather than having to do patient, you can either do patient single position, so on their side, put your lateral cage in, and then with the robot, you can quite easily put screws in while the patient's still on their side. Equally, you can do prone lateral, so you have the patient prone, obviously, and then can put in your screws while they're prone. So rather than doing change of position. So again, I think that's where robot kind of comes in for those awkward angles of screws. I think the robot is very helpful from that point of view. But yes, it is predominantly still used for pedicle screw placement. But then let's say you can move the robotic arm out the way and still then use the navigation that is linked with your robot for putting your cage placement and things. That's I see what most of us do when we're doing robotic assisted T-lifts or PLIFs. Most of us drop our pedicle screws in and then use the navigation element of the robot to place their cages super like so the arm is moved out of the way slightly, but I say you've still got the navigation because it is basically, I mean, the robot is a navigation platform in itself.
Yeah.
So I think like the argument with the cost thing that Marcel has said is that yes, if you have navigation in your hospital, then yes, adding a robot to that as an exception is a large cost. If you do not have navigation, which there are lots of people in the world who still don't have a navigation platform, then the costs of adding a navigation platform in from the beginning are still high because you need to bring in some form of 3D imaging. So whether that's an O arm, a G arm, from Globus or whether that's a 3D C arm, they're still significant cost along with your stealth systems and everything else. So you can be still talking best part of £1 million or $1 million to bring in a full navigation platform. If you're bringing in an O arm and a stealth system, you can be talking best part of £1 million for bringing in a navigation platform from scratch. There are cheaper versions, obviously. So I say, yes, a robot would be $1 million if you're starting from scratch, as is navigation if you're starting from scratch, if you're going for one of the all singing, all dancing navigation platforms.
Yeah, thank you, Stacy. Another burning question from the audience coming from the Harshad Parek. He is asking that do you find complications are less with robotic? What do you think about your own case series before the robot? Did you
So
have more complications or robot reduced already your complications, or you already mentioned that some kind of benefits of the robots coming from, especially if you have a education hospital, then you can easily use the robot for teach your
Robot for teaching is great. But I see the complications that I find that where the robot really comes into its own are for the very large patients, which are the ones that, let's face it, nobody likes doing open surgery in very high BMI. Now, I don't know where everybody else is in part of the world, but certainly in the UK and Ireland, we have a fair few high BMI patients. And doing open fusions or open decompressions are high risk of wound problems, complications, revision surgery. So being able to put screws in, be that with navigation or with robotics, and doing MIS on those patients significantly reduces the chance of wound infections, reduces the blood loss, reduces your surgical time. And I say that's both with navigation and robotics, but I say I find for the large patients it reduces my complications. But I say navigation also does. And I say I'll argue the point for both of them. I say, sorry, Marcel. I'm kind of arguing my own way out of arguing in and out of my own complications.
Okay, great answers. Thank you. What do you think about the learning curve, Stacy? I mean, regarding robot, is it really too long?
So the evidence, if you were to read the literature on it, would say that it's around 20 to 30 cases for robotics from that point of view is what the studies have shown. I think it really depends on how much navigation work you've done before. If you're very au fait with navigation, I think you will pick up the robot in less than 20 to 30 cases. You'll pick it up in a couple of cases because it's really just an extension of navigation. If you've never done navigation before, then the learning curve is quoted at being 20 to 30 cases. But again, it depends on which unit you're in, who you're training with, who you're seeing do it. I came down to a unit who were very navigation happy. And so I would say that my learning curve with it was very short because I was working with a group of people who had already had navigation. I changed hospital. So therefore, the hospital I moved into, everything was navigated. You just had to learn to navigate. And having done everything freehand prior to that. So I would say that my learning curve was not as long as that as the 20 to 30 cases, but the evidence would be between 20 and 30 cases for
Yeah.
robotic. I say, but
Great.
it's the tips and tricks you want to learn. It's not necessarily about the navigation. It's the tips and tricks for how to avoid skive and the complications that Marcel were showing there. And that's where robotics has become much more accurate in the last number of years. Back when we were first really using them in 2018, 2019, when they were still quite novel, they're much less novel now. We hadn't worked out the minutiae of things. And the latest robot actually has multiple reference points. So actually it will take into account that flexible spine or corrections that you make in the spine. So the latest Medtronic robot that's coming out, now you can actually put 5 reference points onto the spine. So it'll be great for deformity correction, because if you change the shape of the spine, the robot adapts to that now. So that's their latest navigation and robotic platform.
Yeah, great, great. Thank you very much, Stacy. And Cesar Popescu from Romania, he actually came up with a nice comment on that. He also agreed with the Marcel that the robot needs a bit more advancement, but we need to still use them and then giving feedback to companies and for more advancement. We all know that, especially for the intrapelvic surgery, the most of the surgeons they are using the Da Vinci. It's a bit different than our robot. So I think it should be much more real robot. So what do you think about both Marcel and Stacy? If you have a Da Vinci in like system in spine surgery, is this help for us or is not that important for especially if as we are putting much more pedicle screw than the resection, the tumors, or doing some kind of soft tissue work, etc. What do you think about this one?
Yeah. Yeah, well, I think what we need to all acknowledge is that technology is very rapidly evolving. So at this stage, I could not see any palpable difference to justify the cost. I like it. I really like the way it is kind of helping with routine, but I can do exactly the same with navigation, and I can do so much more with navigation, which you cannot do with robotics. But things will evolve. Things will really change very rapidly. I showed at the beginning of my presentation this case from Johns Hopkins, where surgery is done from skin to skin without any human intervention exclusively by the robot. And this is something which hopefully will come in spine surgery. I had a couple of slides which I wanted to show before closing my presentation. So this is the current situation. Yeah. So before, I mean, after considering all that we discussed, I think what is important to extrapolate is this situation. So most of us, I believe, already have a car. We all have a navigation which is doing the job just fine. Yeah, we can drive it. To your family, to your partner, that we should buy another car which is 3 times, 4 times more expensive if we already have one which is doing exactly the same job, which just looks cool. Yeah, is it just because it has this robotic arm to hold something and help you? So that's a bit of extrapolation, but that's the reality. But things which I would really like to see is this automatic activity by the robot. And there are some robots which are rapidly evolving. Yeah, so some companies, don't want to mention any names, they are doing this drilling, for example, bone removal. So it is very much the same like 3D printing, but in reverse. You can define the edge of the lamina, and it is with millimetric accuracy. We remove the bone. It can remove the contour around the tumor and take it out. So in the slide, these are the benefits which we would really like to see, this automation. We want to see the robot tumor resection, robotic assisted tumor resection, this precise drilling of the lamina. So basically what we really want to see is the robot doing something while we are doing something else. Dural repair, I don't know, disc removal, decompression, all this kind, something which will evolve very rapidly. But this is just not the right time, in my perspective, from my side, in this age of economics, unless you really have a pool of money which you can spend indiscriminately, and you can buy a robot, then that's fine. For marketing, it's a good toy. It will attract a lot of patients, private patients. But is there any real benefit at this stage? I'm afraid at this stage there is no real benefit.
I would think there's going to be a huge change in the next 10, 20 years, I say. So although the robot has been around for 20 years, I agree entirely with what Marcel's saying about how it hasn't really come on the way that lots of other technologies. It's where they're working away in the background and all these things are coming, and I've seen the bone drilling and things as well. But there's been a lot of pushback from surgeons to navigation over the years. How many meetings have we all been at in the last 10 years where it's I don't need any form of navigation to put screws in. I can put freehand screws in just fine. And we're still having that argument with people in meetings now. Now, most of us here are pro technology, hence the reason we're on a debate about technology. But in that movement has really come in the last 5 to 10 years, really come in the last 5 years, I would say, in terms of where people are now expecting navigation for screw placement, especially in first world countries. From that point of view, you'd be very surprised if you're not putting screws in with navigation in most units now. I say, but that's a new thing. I say, and robots have got a lot to catch up on because although they've been around for 20 years, we didn't use them for the first 15 really in terms of doing an awful lot with them, the same way that navigation hasn't come on huge leaps and bounds. So I think now that everyone's adopted nav and starting to adopt robotics, I think we'll see a huge shift in them in the next 10, 15, 10, 20 years from that point of view. But if we're not on board with them and we're not utilizing them, there's no incentive for the company to push them forward. They'll find something else to do. They'll work on their software planning. They'll go to mixed reality. They'll go to upgrading other things rather than the robot. But whereas you're saying we want to be moving more from the cobot to the true robot. And I think that will come. And we're starting to see technology moving that way.
Thanks, Stacy. Any other comments from the
Can I make some comment?
Please, Mehmet Ali, go ahead.
Yeah. Okay. It was a great discussion, really, and both speakers have defended their sides, and then they have given us all the advantages and disadvantages of both techniques. Actually, I must tell that as Stacy has stressed, the robotic systems use already some navigation. Without navigation, they don't work, as I know. But the robotics in spine surgery is in the very beginning period, probably, because bone dissection has not been applied by robotics because of safety issues. There are many issues. If you don't stop when you see the dura or roots itself during drilling of the bone, you can make big harm. So then they haven't improved their systems in comparison to the abdominal surgery robots like Da Vinci robot and other robots, which are working in a cavity. However, spine is a bone covered place and very precious structures like spinal cord and roots. Probably the robots must be more discussed whenever it comes to time that bone drilling is possible with robotic systems. This is my comment.
So the bone drilling stuff is coming, but the difference between, I think, the spine robots and the intra-abdominal robots are, let's face it, dealing with lots of soft, squidgy stuff. They don't have to change tactile feedback. I say, so we're asking at the moment a robot to change from, as you say, from bone into recognizing the changed medium to soft stuff, and then change the way it works from that point of view. So it has to change from high-speed burr or drill so that we don't go through the dura. But I say what we've had to do is get robots safe with what they can do at the moment, and they can safely put pedicle screws in. Now, we know the accuracy is good. The accuracy wasn't good before because we had problems with skive. We had problems with placement forces onto robots. There was problems with navigation at the start, let's be honest. We've all grown through these curves. I think that as these robots progress, and I think we're going to see a huge change in them in the next 20 years.
And the cost is also very important. It's very costly now.
Oh, it is.
it
But
must be
navigation, say good navigation's
decreased.
also costing.
Probably Chinese companies will come and tell us that we have very cheap robots making also the
But
boundary.
again,
I don't
but
know.
also now companies are realizing that actually putting the robot in, not quite for free, but for a much lesser cost, because they get the implant usage from it. Because let's face it, the companies are not necessarily making money off us buying a robot off them or us buying an O-arm from them. They make the money off of the screws that we use because we're putting that in. So again, that's been a thing for the companies. The companies are all implant companies. So it's not really been worth their while to spend a lot of time focusing on decompression work because they don't make any money out of that. But they know that if we want to be doing this all-round spine surgery, they need to provide us with a robot or navigation that allows us to do all aspects of spine surgery. And I think they're starting to realize that.
Yeah.
And so therefore they're investing time now on the decompression element to it.
You can accept the sentence that statement that robots currently in spine surgery are like very expensive screwdrivers.
Sure. They're expensive drill guides. Very expensive drill guides.
Yes.
As everyone are, they're very expensive
Yeah.
drill guides, but they are
Yes.
also an excellent navigation platform as well. They provide very clear imaging, I say. So yeah, I agree that I say they are that. But if you don't get on board with the technology now, the companies are not going to invest in pushing them forward because
Right.
it's not in their benefit. If we don't engage, they won't engage with us.
Now, I just want to ask to my co-moderators, yes, Pragnesh and Nikolay, do you have any comment or question? Pragnesh, go ahead, please.
Thank you very much. Because I had come out of theater that time, I was still settling. But a fantastic talk initially by Stacy, followed by Marcel. And as someone who has more than 4 decades of experience in spinal surgery and neurosurgery, I think we are going through an evolution. I started without any X-rays, then went to what we used to call 1D navigation. Boss had everything in the brain, three-dimensional anatomy. And you mentioned that you are a deformity surgeon, Alpaslan, and I worked with a orthopedic spine surgeon during my fellowship, and we used to put screws with no imaging at all. From that, we went on to C-arm, now O-arm navigation. I think it is just a question of time. We have to adapt, we have to embrace the technology. Technology will get better, but as Stacy rightly said, that we need to engage with the industry. We make them, and I again quote my famous predecessor and our forefather Lars Lexell, who used to say that fool with a tool is still a fool. So we must use all these tools to our advantage for the improvement of the patient care and for the accuracy of what we do with minimally invasive and with maximum outcome. So I'm very grateful that Mehmet Zileli invited us to join. I'm grateful to the WFNS Spine Committee and my chair, Nikolay, and you, of course, Alpaslan, to make me part of the team. So I'm grateful, and it was a lot of learning. And thank you both, the speakers. Thank you.
Thank you, Pragnesh. Nikolay, do you have any kind of comment or question? I think we missed Nikolay.
Scared him away.
Yeah. Yeah. Okay, then.
Back. Here he is. He's back.
He is back. Okay, Nikolay, do you have any comment or question?
He should be coming back.
Yeah, it was a great meeting, and I have seen 2 great presentations. And yeah, I think both of the presenters had a point. And for me, really, it's difficult to if I have to be objective and choose, it's going to be difficult for me to choose. But on the other hand, I agree with Stacy that if we don't engage now when it's early stages and when we start, it's going to be more difficult to engage later. So I think that I definitely see the benefit of the robot in my practice, not only for educational purposes, not only for marketing purposes. And I would like to be with the wave when it starts, but not when it's already passed.
I think it's easier to learn with the wave, ride with it, than fight it. It's coming.
Yeah, I think we have still some time, but I don't know if both the Duello part would like to say last words. We can start with Stacy and then continue with the Marcel. Do you have anything to add or comment?
And it's the hard. I'd say this was always a hard debate for me because I say I use both, and I say I am a very big navigation fan. I think it kind of comes down to where you are in your center and in your role and what you have available to you. So I think if you were looking to start from scratch and you're buying something, then I would highly recommend a navigation platform of some description. I say if you already have navigation, I would strongly encourage you, where possible, to upgrade that onto a robotic system from that point of view. I say, or look at it doing as a whole navigation suite, which is what a lot of the companies are now moving to from that point of view. They're offering you an imaging system, they're offering you planning software, they're offering you navigation, and usually throwing in the robot now as they go along. So I would sort of strongly encourage people just to get on board with the technology trend if you're not already. And I saw someone commenting about we should video a live robotic session. I'm sure that could probably be arranged by somebody who does robotics as well. I'm sure Nikolay, you could do one, or I could do one. We could get someone to a live robotic session.
We'll leave that for the next time.
Yeah.
Not doing it today.
Your comment is very well aligned with the comment coming from the audience. They would like to have a kind of live robotic demonstration. So I think our societies they are responsible for this comment. And Marcel, I know that you are start to drive your car, but do you have anything before the closure of the session?
Thank you, Alp. Yeah, so I think I completely agree. The navigation probably should be the basic, should be the must. This is the tool which helps to do lots of many things, but robotics, it is an extension of navigation. It provides some additional benefits. So having this rigid arm is more than just having a flexible human tactile feedback, but it should not be treated as a replacement, as a magic tool. Pragnesh very well mentioned, fool with the tool is still a fool. If you don't do the registration accurately, whatever robot you're using, whatever navigation you're using, you still can make big mistakes. We should never trust blindly the technology. This is designed to help us to do things better, not to replace our brain. Yeah. So with navigation, we've learned to do so many things which previously would be considered really complex, really difficult, or almost impossible. Now this is safe and routine procedures. But we should not use it as a replacement for the brain. Yeah, we should still be comfortable with usual anatomy, with usual standard techniques, and use it as an extra bonus, extra technological benefit, which was designed to help us to make things better and safer for the patient and for our coronary arteries as well.
Thank you, Marcel. I would like to thank to all of the societies, which are the International Academy of Spine, Middle East Spine Society, WFNS Spine Committee, and also AO Spine Europe for their great contribution for this fantastic event and webinar. I'm sure that our collaboration will continue in the future with other hot and interesting topics. And thank you very much, and have a nice evening.
Thank you, all the speakers and all the moderators and all the participants. Wish to see you again in future meetings.
Thank you.
Goodbye.
Thank you. Thank you for
Goodbye.
invitation. Thank you for joining.